Шановні колеги, шановні друзі, сьогодні 28 травня, 17:00 за Києвом, і це означає, що ми розпочинаємо наш 14-й науково-практичний семінар на шляху до покращення здоров'я жінок, які живуть з ВІЛ Україна. Наш сьогоднішній вебінар, наш сьогоднішній день триватиме орієнтовно 1 годину і 45 хвилин.
To last approximately for 1 hour, 45 minutes. And today we are going to focus on mental health and adherence in women living with HIV. And also I would like to say that our webinar was organized by working group of EACs on AIDS issues called Waves Against Virus in Europe, which is WAVE, and our working group is focusing our attention on women's health, women living with HIV. All right, so let us start from introductions of our co-chairs, and I would like to give first the floor to Svetlana Antoniak, infectious disease specialist and honor doctor of Ukraine, working at the Department of Viral Hepatitis and HIV at Romashevsky Institute of Epidemiology, National Academy of Science, Ukraine. You're most welcome. Dear colleagues, I'm very pleased to welcome you to the 14th WAVE EX webinar on track to improve the health of women living with HIV, Ukraine, and sincerely thank you for your interest and for finding the time to participate and discuss important issues regarding modern approaches to treating depression, anxiety, mental health. This is the topic of our session today, with a special focus to the needs of women living with HIV. I would like to extend my warmest thanks. Traditionally, this is our tradition, to Dr. Caroline Abby Pop, Master of Sciences. She works as a consultant obstetrician gynecologist and researcher, Department of Infectious Diseases at the University Hospital of Bern, Switzerland, and she is a co-chair of our meeting today, and whose mini lecture on menopause and mental health in women living with HIV we will listen to and discuss today. And it was actually Caroline Abby Pop back in 2019, together with Professor Justina Kowalska of the Medical University of Warsaw and Professor Fiona McCarthy, who worked at St. James Hospital in Dublin, who inspired us to organize the WAVE EX webinars on track to improve the health of women living with HIV Ukraine. And Caroline Abby Pop's research interests focus on menopause in women with HIV. As clinicians working in HIV care, we understand the importance of openly discussing fertility, contraception, and menopause with our patients. But the question is, do we always do this in our routine clinical practice? And do we always do it correctly? We believe practical strategies that help doctors create an atmosphere of trust and effectively support women living with HIV are really very important. We are very grateful to the speakers and discussion participants from Europe for continuing to support Ukraine. We would like to thank Dr. Jota Lourdi from Athens, Greece, Vice Chair of WAVE, who is also co-chairing today's webinar, and Dr. Guida da Ponte and Dr. Erika Ferrari, who live and work in Portugal and will be speaking today about issues related to depression and anxiety. And we hope that the lectures and discussions will help us improve communication and enhance support for women living with HIV in our daily clinical practice. Many thanks to Dr. Oleg Sobko, a psychiatrist and addiction specialist at the Prikarpatia Regional Clinical Center for Mental Health in Ivano-Frankivsk, Ukraine, for the clinical case diagnosis and treatment of depressive disorder in a woman with opioid use disorder who is living with HIV and is on opioid agonist maintenance therapy. Ukrainian doctors' interest in the EX-WAVE webinar focusing on key health issues for women living with HIV remains high. A big thank you to our participants from Ukraine for continuing to work despite these difficult days, air raid alerts, and sleepless nights. We are now working together on our webinar. We recognize that it is important to address the needs of people living with HIV and to continue providing support. In fact, under the current martial law in Ukraine, this may be even more crucial. This is a testament to the resilience, consistency, and stability that we all so desperately need. And today we are focusing on important issues related to modern approaches to mental health, with special attention to the needs of women living with HIV. Today's moderator, Sergei Antoniak, a research fellow in the Department of Viral Hepatitis and HIV at the Clinic Romashevsky and a member of WAVE Scientific Committee. Thank you for your attention. Thank you so much, dear Svetlana. And now I would love to give the floor to our co-chair, Ms. Chota. You're most welcome.
Hello, hi. I just want very quickly to welcome everyone on behalf of WAVE. You know who we are because it's the 14th time that we're doing this seminar. And for those who don't know, I just want to repeat that WAVE is very focused on helping where there are barriers to achieving good HIV care for women, and also where there is a high burden. So we're very keen on helping the Ukrainian community of HIV doctors. And I'm looking forward to listening to all the presentations and this amazing panel. So thank you for being here today.
Так, дуже дякую. Дуже дякую, пані
Thank you
Гьота.
so much, Ms.
Так, і що,
Gyota.
напевно, ця
And
бойова подруга, наша добра знайома
now,
Керолайн.
a person we all know very well, Caroline.
Керолайн, прошу.
A very warm welcome from Switzerland to everybody, especially to Sergei, Svetlana, the co-chairs, and all the participants. It shows your dedication to go on with that workshop, which took place 2019 live in Kiev, and I will never forget that great time to this interaction with you. Since then, we had to go online, but it's so important, the topic we have chosen today, mental health in stressful times, with treatment interruptions and displaced women across Europe. We need that very much because all our quality of life is focused on well-being and mental health in those stressful times. And I'm so glad we have specialists giving talks, and we have enough time for discussion. And all the participants can maybe ask questions or can also bring their questions online today for us. So thank you for being here, and thank you for your commitment to go on with our workshop. It's very good for everyone, for us. We learn from you, and I wish you a wonderful workshop and loads of inspiration for your daily work and your hard work. Thank you.
Дякую, дякую, пані Керолайн.
Thank you so much, dear Caroline. All right, a couple of household issues, dear colleagues. Just to remind you that we have a YouTube broadcast, and we will be very grateful if you ask your questions in this broadcast chat. We will try to answer your questions, any of your questions, and we will make sure we will discuss them during Q&A. Just to remind you, you'll be able to get your certificates of participation in our webinar, and the day after tomorrow, you will have to undergo survey, and this is not to assess your knowledge, this is survey just to assess the quality of our webinar, how we worked for you. And just a couple of words about tomorrow. Tomorrow we will talk about metabolic disorders in women living with HIV. Please join in, and we will start also 5 p.m. Kiev time. And now I think we will go on to our agenda. It's quite busy agenda for today,
з
and we
міні-лекції,
will start with mini lecture Depression and Anxiety in Women Living with HIV. That's going to be provided to us by Vida da Ponte, Master of Science, Doctor of PhD, and the doctor consultant on psychiatry, interconsultative psychiatry at the Department of Mental Health at Health Arco Ribeirinho, Portugal. Ms. Guida, if you would like to say a few words, welcoming words to our participants, and then we will go on.
Yeah. So good afternoon. Thanks. Thank you for this invitation. It's really a pleasure to be here to contribute in some way in this initiative, this important initiative, and to contribute for the knowledge about mental health problems in women living HIV. And especially for me, it's a pleasure to contribute and to help our Ukrainian colleagues and the Ukrainian people. So thank you.
Дякуємо, дуже дякуємо вам.
Thank you very much.
Після лекції
After the lecture, Ms. Guida, we are going to have a short Q&A session, some discussion. Then we will have a second mini lecture given by Caroline Ebipop, doctor consultant, OBGYN specialist, infectious disease department, Bern University Clinic, menopause and mental health in women living with HIV. After that, again, there'll be a short Q&A question and discussion, and then we are going to look at a clinical case, diagnosis and treatment of depressive disorder in a woman with HIV and opioid dependence syndrome or use disorder who is on opioid agonist therapy, methadone. And it's going to be presented by Dr. Oleg Sobko, psychiatrist, addiction specialist, substance maintenance therapy at Prikарпаття Center Ivano-Frankivsk Council. A few words to our participants. It's my pleasure to be here. This is my first time to be at an event like that. I hope to learn something new, and also I'll be glad to share my experience managing patients with mental health disorders in women living with HIV. And I wish everyone a very productive day. Thank you.
Дякую, пане Олег. Дуже дякую, що ви доєдналися до нас
Thank you
сьогодні.
so much that you have
І
joined.
також
And
ще
also,
один наш учасник,
we
яка
have
доєднається до
another
нашої
participant who is
дискусії
going
про
to join
оголошення.
our
Це Еріка
discussion
Феррарі
is
з
Erika
Португалії,
Ferrari
доктор
from
медицини,
Portugal,
магістр наук,
Doctor of
доктор
Medicine,
філософії,
Master of
з
Sciences,
постдокторантурою в галузі
PhD,
інфекційних хвороб із фокусом на
Fellowship
ВІД,
Infection
лікар-спеціаліст
Diseases focuses
у
on
місцевому
HIV
об'єднанні
and
охорони здоров'я
specialist at a local health
Дутежу,
unit
Португалія.
Studio do
Пані
Tejo,
Еріко,
Portugal.
можете теж
Ms.
привітати
Erika, if you
наших
would like, you can say a
глядачів
couple of
перед
words
тим,
to
як
our
перейдемо до
participants
першої лекції.
before we start our first lecture.
Hi, everybody. Thanks a lot for this invitation and for this opportunity. I'm very happy to be here. And I hope everybody enjoyed this discussion.
Так, дуже дякую. Ну що, колеги, тоді
Right,
можемо
thank you
переходити до
so
нашої
much,
першої
dear
лекції,
colleagues.
яка
So we will
називатиметься
start
«Депресія
our
та
first lecture,
тривожність
Depression
у
and
жінок і
Anxiety in
чоловіків»,
Women
яку
Living with
представить
HIV,
пані Гуїда
and it's
Дапонте.
going to be presented by Ms. Guida da Ponte.
Today I'm talking about depression and anxiety in women living with HIV. So I don't have any conflicts of interest. So this is our agenda. So I will talk about epidemiology and risk factors, pathogenesis, screening and diagnosis, and treatment. So starting with epidemiology and risk factors. So I believe that you all know, so these are some general issues. So we have we know that nowadays, and this is World Health Organization data, so we have more, the majority of people diagnosed with HIV 2023 were from the eastern part of the region. And the thing is that the majority of, or substantially of these people diagnosed with HIV were women and girls. So it's a fact that we have a problem of infection in women in Europe. In general terms, what the study says is that people living with HIV suffer most, comparing to the general population, from depression and anxiety, just in the consequence, adjusting to the diagnosed, and to, of course, adapt with a chronic infection and a life-threatening illness. The prevalence, the studies about the prevalence of depression and anxiety in people living with HIV varies according to the country. Mostly it's explained because of the different parts of the world that the studies are done and the different measures that are used. But what we know is that we believe, the studies believe, that the prevalence is higher in low developing countries because of stigma, and the majority of stigma complaints and problems in this type of countries. So also, in general, depression, we know that depression occurs in 2 or 4 times higher in people living with HIV, anxiety also, and in terms of the many pathologies that we have in anxiety disorders, generalized anxiety disorders is one of the highest types in people living with HIV. What we also know is that depression is related to higher HIV viral roles and less immunity, namely CD4 counts. Even after controlling the impacts of adherence. So what we know is that depression and anxiety have are a prognosis factor in people living with HIV. Also, what we know is that general risk factors for depression and anxiety in all the population is low income, unemployed, social isolation, like the marital status, like being widow and female, is a well-known risk factor, and other risk factors as substance abuse, including alcohol, and past psychiatric history. So what I'm going to show you is a lot of studies, and the study, you have a lot of studies about prevalence in generally in people living with HIV, and also specifically with women. Although with women, the number of studies are less, of course, but what the study says, and recent studies says, is that, of course, as I told you, the prevalence varies according to the measures in the country that are measured. But the study in Ghana shows a prevalence of depression of 28%, anxiety 40%, stress 10%. And also studies, as I told you, what shows, as I told you, was that females and social isolation, people without a regular partner, and people with low education have a higher risk of depression or anxiety. Also, and what the studies conclude, this specific study, is that women, of course, continue to experience inequality due to increased vulnerability and discrimination of various forms of abuse. So these are the studies in sub-Saharan Africa. What shows is that the prevalence varies, of course, and what are the predictors of mental health outcomes in the context of HIV/AIDS is violence, stigma, childhood traumas, sexual abuse, poverty, unemployment, social isolation. As we know, and is very well described in the literature, is that social support and resilience are protective factors. So the relation between HIV and stigma, and stigma is a bit complex. So Stigma and discrimination is one of the major factors that people with HIV are confronted in general. And we also know that stigma experience have lower levels of perceived social support. This is easy to understand. If people feel more alone, they will feel the intensity of stigma in higher levels. What I also want to give you as a message is, of course, people feel more stigma, but this depends also in the way people cope with stigma. And we know that coping style, that is the way people deal or adapt to difficulties, is also important as a prognosis factor. So this particular study tried to show, well, how women decide to disclose the HIV infection. So how people, and specifically women, evaluate the threat that is stigma, that is the impact that the HIV diagnosis will have in their lives, and who do they tell? So in general, women disclose to people that are close for them, of course, sex partners, close families and friends, and healthcare professionals. So the question of disclosing or not depends as the way people evaluate the threat. So Lazarus and Folkman have a good model of how that explain how people evaluate the threat. So if, as this image in the left, if people evaluate the people will evaluate the threat as a harm, a threat, or a challenge. And according to the coping style, and if people face this threat as a problem focus, like a more cognitive way of thinking, or a more emotional focus, will have an emotion outcome that is will determine how much distress this evaluation causes. And at the end, this evaluation will determine if people disclose or not. One thing about women specifically is that, and as we all know, because of cultural issues and the way society see women has always been viewed as vectors of HIV transmission. So one of the weights that people put when deciding how to disclose or not, and when and to whom, is this standards of our society of morality and how people will think the others will judge. This is a very interesting study done in southern United States. So I found really interesting how to understand how parts of developed countries. So developed countries is not the same as people see, and how is not the same of developed way of thinking. So the southern part of the United States is a very conservative part. And what do they found out was that in this specific part where more conservative societies live, is harder to disclose because specifically stigma, and specifically HIV-related stigma, that is, as you know, negative social reactions towards people living with HIV. We have also to understand in stigma that one thing is the stigma that society put to people. The other thing is how people experience stigma and how people internalized stigma. That is how the stigma affects the self-image and value. So stigma can be can be a bad psychological and give bad experience to people living with HIV because of this internalized stigma. So what the study concludes is that there is a need for patient-centered interventions to mitigate this kind of stigma that is closely related to moral issues, specifically related to the role of the women. So these are the studies. What they show is that what I had said you before, people that have higher levels of social support are less likely to report HIV-related stigma. These are the studies below do a link between social support, depression, anxiety, and previous history of mental illness, as we all expected. So these two studies keep into attention the question of age. So these two studies found out, of course, that depression and anxiety are more prevalent in women and more prevalent in younger age. So this specific time of the life is a risk factor to us to be into mind when treating patients. The studies do a connection between stressful life events and depression and anxiety and PTSD. So what we all know is that this is general risk factors, is that having a stressor like recent death of a family members or severe illness of a family member is a risk factor for depression and anxiety. And the number of stressful life events put more risk into. So if we have a patient with a lot of stressful life events, we all know that this is a patient that is more likely to suffer from depression and anxiety. So, but talking about risk factors, and we all know that, and the risk factors are common in the studies. But another question is to understand how the risk factors can cause mental health illness. And during the 70s, 90s, there was a lot of developing in psychosomatic medicine, where the studies try to understand what kind of central nervous system imbalance caused the stress. And this is a general fact nowadays, that we know that, okay, people are exposed to stress, and not everyone have a mental illness disorder, because people have an adaptive biologic response to stress that we call allostatic mechanisms. This is very well described in anxiety disorders. So the human being is faced with a stress factor, so he have the capacity to adapt and to balance the stress and the coping mechanisms. But another question is, that is the case of HIV, when people have a prolonged exposure to stress and having an HIV diagnosis with all the implications, that is stigma to the society, internal stigma for me, or the cognitive way of thinking, I will live with a life-threatening condition, I will need treatment for all my life. So this causes a prolonged exposure to stress. So, and when human beings faced with prolonged exposure to stress, the coping mechanisms fail, namely in terms of central nervous system. And one of the explanations is that the immune system can't balance this allostatic load that is overwhelming. So this is the physiopathological explanation, how people, that explained why people develop depression and anxiety in conditions like HIV or cancer or autoimmune disorders. So I already start to talk about pathogenesis. So in terms of depression, that is very well described in psychiatry. We know that we have a lot of causes. So the causes mixed together, and then we have the clinical picture. So we know that people have genetic factors that predispose to depression. So that's why we ask about previous psychiatric history. We know that in terms of physiopathological system, we have neuroendocrine factors, neuroimmune factors, and the disorders in terms of the imbalance of neurotransmitters. And this altogether is our explanation, physiopathological explanation of depression. So it makes sense in people that are living with HIV, that are with overwhelming stress because of the diagnosis and the implications. It makes sense that these people have more risk of depression. So this is a good image that puts all the factors in a line, and the balance of the factors will lead to the clinical picture at the end, developing a depression. In terms of physiopathological mechanisms, these are very complex. And specifically in HIV, the imbalance and the state of pro-inflammatory cytokines is very complex, and they share the same pro-inflammatory cytokines in depression and HIV. For example, we all know that in depression we have high levels of interleukin 6 and TNF, and also in HIV, in terms of imbalance of the central nervous system, we know that this kind of pro-inflammatory cytokines are higher. So if we have that two effects, it's easy to understand why people with HIV have more higher rates of depression. So the mechanisms are the same. So although the study says, okay, it's unclear if these mechanisms are the expression of peripheral inflammatory process, but the question is if these are primary central nervous system process extended to the peripheral organs, because we know that pro-inflammatory cytokines are all over the organism. So what is most believed nowadays is that, okay, HIV and depression have a cyclic role, and they influence themselves, popping up more intensity or more frequent rates of depression and anxiety. And that's why people living with HIV have more rates than the general population. We also know that although the medication, the heart is very different from the past, and we have some good examples of mental health disorders that I don't like the word caused, because caused is a relation of causality that is very strict, but let me say predisposed or predisposed factors. We know that we had in the past and also used nowadays in some countries, some heart medications that were linked to mental health disorders, namely the links between adherence and depression, especially patients with suicide ideation, so that we had to avoid. We know that nowadays heart drugs are more have a better profile in terms of side effects. The question is that drugs are not perfect, of course, and we have also with lower rates, of course, but we have also some mental health issues described with rilpivirine, dolutegravir, and bictegravir, specifically according to the literature, more with dolutegravir. So this is the data, but how to screen and diagnose? Well, you have the European AIDS Clinical Society have a good guidelines. They have better guidelines than psychiatry. So screening of depression, what they say, and I agree, of course. So in general terms, screening of depression and anxiety, and I have some slides about anxiety, must be done at each routine HIV visit, especially for people that have risk factors, namely a family or personal history of depression, older age adolescents that I talked to you about. So the age of people are important. People with past history of psychiatric history, namely drug addiction, if use of evidence, of course. Also, as a part of investigation of neurocognitive impairment, as I told you, the neurocognitive impairment, namely HIV-associated disorders, cognitive disorders, do a differential diagnosis with depression. And also, as I told you in the beginning of this presentation, people that are socially isolated, because we know that social support is one of the main factors for depression and anxiety. The screening can be done by two simple questions. That is our major focus when we treat people with depression. There are two questions that we always want to know. If people have been felt depressed because of depressive mood, and I believe this is more accurate than depressive mood because, well, you know, if I ask to Portuguese people if they have felt depressed, the majority will say, okay, I'm depressed. But the other question is the cognitive core complaint of depression, that is anhedonia, that is, have people lost interest in activities that they usually enjoy. So this loss of pleasure is a very important, more or less accurate complaint of depression in terms of screening. Also, European AIDS Clinical Society have questions about the risk of suicide. This is also important. Suicide can be another class because this is very, it's not so simple. But the message that I want to pass is that we only can do a correct screening of suicide if we ask to people if they want to die. So don't be afraid, please ask to people what they feel. So the guidelines also say when to treat and not to treat, but in when to seek an expert. So in general terms, okay, that was screening that we can do with questions. If you have some doubts as HIV physicians, please send to the consultation experts, in this case, a psychiatrist, to evaluate the patient. So this is our criteria to diagnose depression. This is only just to give you information, but as you can see, so depressed mood and anhedonia is the major complaints of depression, and then we diagnose putting more doing the sum of the complaints of the patient. So we do categoric diagnose, as we call it, according to our manuals of classification. So the general message is, please don't be afraid of treating people that you evaluate, and of course, if you have treatments, doubts in the treatment, seek help from or talk and take the doubts with an expert. Okay, about anxiety. So about anxiety, you have a lot of instruments that you can use, a lot of screening instruments that you can use. The European AIDS Clinical Society gave an example of the generalized anxiety disorder screening tool that is an instrument specifically for the generalized anxiety disorder. And what they say is that you need to seek expert advice to diagnose panic disorder, social phobia, and PTSD. Well, it's not wrong, of course. This is our guidelines, but the question is, well, I don't know if you need to seek expert advice to diagnose panic disorders or social phobia. Maybe for PTSD that's a bit complex. But as you can see, this is, I will not talk to you about the in detail about all the diagnose. But for example, to diagnose a panic disorder, we all know, we don't need to be a psychiatrist to know that a panic disorder is characterized by panic attacks that are characterized by a sudden, unexpected, overwhelming feelings, physical feelings like tachycardia, hyperventilation, cognitive feelings that I'm afraid of dying. So this is a cognitive and a physical combination of symptoms. Also, what this guideline says, okay, of course, if you have a screening with only symptoms, you can do non-pharmacologic treatments. But the question is, and because anxiety can be really overwhelming and can cause severe incapacity, in my opinion, please consider treatment with antidepressants to keep people function and close to the society. The problem is when people lost function and lost capacity to live in society because of depression and anxiety, of course. So what about the treatment? So I really like this image that put into focus what kind of treatments do we have? So we have antidepressants, of course, because we have well described our theory of neurotransmitters, and that's why you use SSRI. The SNRIs is according to the mechanism proposed in depression and anxiety. The mechanisms are similar, as you know. But also, we have another theory that's what I was talking about in the slides about pathogenesis. This is not only about neurotransmitters. This is about inflammatory theory. So we have some studies that they're not FDA approved or European approved, but we have some very interesting studies. As depression and anxiety can cause a pro-inflammatory reaction, as I told you, and as NSAIDs can relieve the symptoms of depression and anxiety by decreasing the levels of pro-inflammatory cytokines. This is a slide just to show you why the physiopathological mechanism is not so simple, and why it is important to treat depression and anxiety. Because you're not treating depression and anxiety, you're not treating the mind only, we're treating the body. We also have, and as I didn't talk with detail, but this question about inflammatory is about the hypothalamic pituitary adrenal axis and the dysregulation of glucocorticoids. And of course, this all brings to the inflammatory theory of our depression and anxiety disorders. So, but in objective ways of talking, treatment of depression and anxiety is done by antidepressants and by non-pharmacological interventions. This is a very interesting study. I will just talk to you briefly how non-pharmacological interventions done specifically in developing countries can help, and specifically done with women, can help in complaints of depression and social support. I believe that we have I believe, no, I'm sure. It's a psychiatrist. I believe she's from Uganda. She have a very nice study about the group support done by peers in Uganda with good results. Well, but in this study specifically, and this is the majority of the studies, they focus on women that are mothers or expecting mothers. And what this study found out was, okay, we do a lot of interventions. The majority of our population is mothers or pregnant women. This helps, but there's a need for support interventions for women in general, especially that teach women her rights in terms, because of the questions of violence, stigma, moral pressure from society. So there's a need to increase this kind of interventions that are beneficial to all the women in all ages and stages of their life. So these are the types of interventions that they done, and what kind of endpoints do they evaluate. And as I told you, what they found out was efficacy in terms of depression, social support, and coping mechanisms. Of course, if we teach people how to cope, people will learn and have better mental health results. This is very straightforward. And in terms of prescribing, and I'm almost at the end of my presentation. So what we know in general in people living with HIV is that they will have more side effects than in general population. So the question is, start with a low dose, titrate according to tolerability and response, use simple dose regimens. So when I treat HIV, people with HIV, living with HIV, I try to choose only one drug. I try, no, not every case is possible, but I try to use only one, or the least, or the simplest dose regimen. In terms of depression, so the first line agents in terms of antidepressants is the agents that have less side effects and less potential for interaction. This is one of our guidelines is the Mauser guidelines that are UK guidelines. So what they suggest is escitalopram and citalopram. So as you know, escitalopram is a baby son of citalopram. The only thing that we need to keep into attention is the need to ECG monitoring because of the risk of QT prolongation. Also, mirtazapine can be a good option because, as you know, mirtazapine is an antidepressant that have sedative properties. And for people that don't sleep and are depressed is a good option because it's only one drug to treat all. Also, as you know, we try not to use all the antidepressants as tricyclics because of the burden of side effects. In anxiety, as you also know, SSRIs are the first line options. Anxiety is treated with antidepressants. We can use benzos in the acute symptoms. And what is recommended in people living with HIV, precisely because of interactions, drug interactions, is lorazepam that isn't metabolized by the cytochrome, by the liver, and clonazepam that, although because don't have an active metabolite, have a longer life than lorazepam, but don't have active metabolites, so the risk is lower. So nowadays, and with the development with heart, of course, what are the major preoccupations that we have when prescribing psychotropics with heart is mostly QT prolongation, because we know that the antidepressants have this risk, also heart drugs. So in my outpatient clinic, I always ask for an ECG in the first appointment. In the general of patients, of course. Also, the question about metabolic syndrome, we know with heart that is a risk over the years, and it's well described with some of our drugs also. So we need to keep this in mind, to evaluate periodically the patients with blood tests and all of that because of this risk. This is more rare, the risk of myelosuppression with, well, it's rare with the majority of drugs. We only have one with a bigger risk, but it's for other conditions, not for depression and anxiety. And this is a more recent preoccupation. When I say more recent, over the last years, is when we use antipsychotics and the risk of prolactin elevating levels and the risk of low bone mineral density osteoporosis. And also because we know that people living with HIV have also this risk, so we can potentiate this risk giving to drugs that have the same risk, of course. And I will not talk about these boring tables, but because I believe that you will stick with my slides. This is a useful tables with interactions, specific interactions between our drugs and heart medication that can be useful for you in terms of metabolization by cytochromes. And yeah. Thank you for your attention.
Thank you very much, Gita. Thank you so much for this very comprehensive talk. I learned a lot. And I think it's such an important topic between psychiatry and ID physicians and looking after those women. May I ask you, Gita, do you have any advice for us clinicians when we have women with those symptoms? Would you give us, would you ask us to work with a psychiatrist, or can we also prescribe medication, or would you just wait for a better, more detailed?
Yeah. Thank you for the question, Caroline. So that's an important question. So I believe that you can start with the medication, and it's more safe, and it's better for the patient if you have suspicion of anxiety or depression. You can safely start nowadays with antidepressants. As I told you, there are no major risks with the current heart medication. And you can save time, because if we don't treat mental health disorders, they will worsen, and the patient will have consequence on that. So yeah, my answer is yes.
Thank you. Are there any questions from the audience online, Sergey?
Yes, we do have some questions from our participants. For example, the following question. As long as it was proven that for etiology of depressive disorder, stigma plays a certain role, do we think that we can prevent depression in women if we fight stigma? And which interventions with this regard would be the most efficient? Thank you.
Thank you. Good question. One of the major worldwide mental health programs is the prevention of mental health disorders, and the prevention of that is trying to improve the known triggers of mental health disorders. And yes, stigma is one of them. One of the measures that very well described in general to prevent mental health disorders is education. So if we teach young children and adolescents, because teaching the young is preventing the illness in generations. So education, school, fighting stigma, trying to teach them what is stigma, what are the consequences. We are improving mental health in this generation and the generations forward. And yes, now talking for the women specifically. So in more conservative communities, and here in Europe, we have a lot of conservative communities still, trying to in our outpatient clinic, trying to empower the women and trying to teach them, look, this is not your fault. Look, the society put a lot of moral pressure on women. This is important for their well-being. So we can also teach our patients that to fight themselves and give a coping mechanism that I was talking about, trying to give them coping mechanisms to fight stigma. Yeah.
Дуже дякуємо вам за відповідь.
Thank you so much for your answer. Dear colleagues and dear speakers, chairs, co-chairs, participants to the discussion, maybe you have some comments or questions to our lecturer. If I may, I have a question. Of course, thank you, first of all, very much for this presentation. I have two questions. What do you use to augment in depression or in anxiety? Number one, antidepressant, and number two, do you use in your country such interventions as medical stimulation of the brain or psychedelic drugs?
Thank you for the question. I believe that I don't know if I correctly understood what kind of antidepressant do I use. It was that the question, the first question? Sorry.
Yes, to augment, to strengthen. If there is no response from the first antidepressant, do you switch and use it from a different group, or what do you use?
Yes, thank you. So we start with generally with the SSRI, and we reach to the maximum doses. If the answer isn't good enough, if the patients don't enter into remission, what we do is we change to a different SSRI. It's not mandatory to go to the other class, to the other level, to the second line, that is SNRI. So as an example, if a patient is very anxious and she is working and she wants to have an active life, and she's on heart medication and she do hypertension, so she have a lot of medication. So I will choose, for example, escitalopram. It's good for depression, good for anxiety, no interactions. And I reach to 20 milligrams. If the patient doesn't respond, I can change to sertraline, and trying to reach for 100 milligrams. That's also a good antidepressant with more interactions, but in general terms, is safe. In terms of TMS and psychedelics, yeah, we have here places where we deliver TMS, generally private places. In our national health system is not very usual. Some places do electroconvulsive therapy, but for depression, as you know, TMS is also approved and is not so invasive. In terms of psychedelics, so we are facing a boom in terms of research. So we recently, I believe a year from now, we have approved esketamine for resistant depression in the psychiatric mental health patients. And we are some places are also doing ketamine for depression, for palliative care. So yeah, in general, we are facing also, like the rest of Europe, a boom in psychedelics. Although ketamine is not exactly a psychedelic, but ketamine specifically was approved by our government.
Thank you very much.
Дякую, дякую за хороше запитання і цікаву
Thank you.
відповідь.
Thank you so much for
Пані
wonderful
Світлано.
questions, interesting answers,
Я
Ms.
теж
Svetlana.
хочу
I also would like to thank
доктору Гіді за таку
Dr.
чудову
Gida for this really
презентацію.
wonderful
Дуже хочеться
presentation.
спиратися на фахівців
Of course,
психіатрії. Ми, звичайно,
we
намагаємось
always
медикаменталісти,
listen
ми
to
намагаємося
our colleagues from
теж
psychiatry.
базові знання
We try
мати
as
і
infectious disease
приміняти, тому
specialists
що
to
ми
have
не
at least
можемо
basic knowledge
будь-якого
and apply
пацієнта
this knowledge
направити до
for our
психіатра. Це
patients.
не дуже, і пацієнту
We
це
cannot refer every
дуже
patient
важко.
to a psychiatrist. You know, it's
Краще і
quite difficult
самому
to do. They are
знати,
reluctant to go see a
базис,
psychiatrist.
звичайно, коли
So it's
складний
better
випадок,
to know
то
some
тоді
fundamental
треба
basic things
спиратись на
ourselves. Also, of course, saying that, I have to say that if it's a complicated case, we would need a mentor or a supervisor. Again, a wonderful presentation. Thank you once again. And I would like to just mention with regards to integration. Of course, and we are just on our way to integration with other specialties in Ukraine. Of course, we would like to know how to do things on our own, but at the same time, would be nice to have a very easy opportunity to get a consultation from a subspecialist, not to send patients every time to a new subspecialist, but for us as specialists to be able to communicate online, for example. We are trying to do that. This is number one. And also what I'd like to say with regards to stigma, something to mention about stigma. I agree absolutely, wholeheartedly with Dr. Gida. It's very important to have measures, interventions to decrease stigma in society. But what we can do as doctors, we might to also help achieve zero stigma, maybe just to show our corporate culture, our corporate ethics, and demonstrate it in our healthcare facilities, in our society, in our circle. Of course, in order to decrease it in society, it would be the most important. But what we can do is start from ourselves, okay? And it would be better for us to achieve this result if we, as exhibiting a very important component of corporate culture, if we in our circle show how to do that and decrease, significantly decrease stigma. Thank you.
Дуже дякую, пані Світлано. Так, Еріко, бачу.
Thank you very much. Erica, I can see your hand raised.
Прошу.
So thanks a lot for your speech, Guida. And I would like to say some words about lifestyle interventions in these patients, because I think it's very important also as the medication. Because I also have an experience when I worked in Brazil with a group just for women. And these women can share these problems, these fears, it's a group with just with women and the psychologists and the infectious disease, the doctors. And most of these women were pregnant at that time. And what we feel about that is that when they share with the others and they feel that they have the same problems and the same circumstance, they feel better. Do you know? So I think it's very important when we can do that. It's like a multidisciplinary intervention in this patient, even if it's necessary to give a medication, for example, for depression or anxiety. I think it's very good for the patient when obviously they agree to share the diagnosis and their problems with the others, because we are going to talk open about HIV and everything. And if they agree, this kind of integration with the patients was very good. It was for example, we learn a lot with the patients, and they learn a lot with each other when they share the same problems and expectations, and so.
Let me comment. So we are all physicians. We focus on medication. My first slide was about psychotherapy. So psychotherapy is a treatment, and it's an adjunct treatment with medication. So that's what Erica described for me. I will call it psychotherapy, not lifestyle. These things have to be serious and have to show evidence, medical evidence. If it isn't evident that this have benefits, well, it's not for us, you know. So and I told you that there's a colleague of us in Uganda that are doing a wonderful work, because the resources in Uganda are less, of course, and when we don't have medication, we use what we have, and that's another conversation that we can have in different circumstances. But she's devolving this kind of psychotherapy with peers. So you have a lot of things well described and with evidence in the literature. A second thing that I want to keep into attention: do not oh my God, I can't say the word. Do not devalue.
Underestimate.
Yeah, thank you. Mental health disorders, because when they are in the course, they flow their course, and they are very, very incapacitating. And in HIV people, the consequences can be lack of adherence, AIDS. So the consequences are very hard. So do not devaluate the symptoms, especially if patients have illnesses like HIV. Yeah.
Thanks.
Quick question for me, please. Very quick question. Practical one. Thank you, Gida. You covered everything. From the side of the clinician who sees a patient with a new diagnosis, and we start immediately on treatment, and the treatment is 99% of the cases is integrase inhibitor, which has listed as adverse event depression. So you see the patient 1 month later or 2 weeks later, and you see that they start having some symptoms that sign you that you may have a depression here. So are there any clues to guide you whether you should look at the the adverse event of the treatment, or is it a reaction to the new diagnosis and the new reality? How do you handle things in the very beginning, if there's a way?
Yeah, that's a hard situation. So what I do is with my infectious disease colleagues in my hospital, what I try to do is, if they have a suspicion, they send the patient to me and we try to figure it out. Because as you know, side effects can only be established by temporal causal relation. So it's safer if you suspect the patient is drug related, but if you feel that the patient needs this medication and it's the best medication, if you have the resources, send them to the psychiatrist. You know, I'm from the time when here in Portugal we treat hepatitis C with interferon. Do you remember? So I had one patient that I try. Well, in that time, when you have depression with interferon, you have to stop it. So we try to keep the patient into treatment in interferon, and I treat the depression side by side with the infectious disease colleague. And so, so this is the best way to handle difficult situations.
Thank you.
Так, колеги, дуже дякую.
Dear colleagues, thank you so much. Thank you, Ms. Gida, for wonderful lecture, wonderful discussion, and we have to move on according to our agenda. I'm a timekeeper, so I have to do that. So I suggest we go on to our second mini lecture for today by Caroline Abipop, and the lecture is about menopause and its impact on mental health. Caroline, you're most welcome.
Thank you very much for giving me the opportunity to talk about menopause and mental health in women living with HIV. I have no conflicts in regard to this talk. We will talk a little bit about epidemiology, about the symptom burden of menopause, comorbidities, and treatment options. First of all, it's 53% of the global population of people living with HIV are women. So it is an important topic to also talk about the menopausal transition and to talk about aging. If we look closer, we can see that about 1/4 of all people living with HIV are aged 50 years and older. This accounts to about 10 million people, and of those, we're talking about 5 million women aged 50 years and older living with HIV worldwide. And those are the ones transitioning through menopause. Menopause is a clinical diagnosis, and everybody can make this diagnosis because menopause is the last physiological menstruation in a woman's life, followed by 12 months of amenorrhea. And then this time is called postmenopause. But in regard to symptoms, the most important time is the menopausal transition time. This is when irregularity of the menstrual period starts to occur. Normally, it takes place every month, but then there's an irregularity between 7 days and some months. The age at menopause is crucial because we have to diagnose early menopause. The physiological menopause takes place between 45 and 55 years, with a median age of 48 years. But there's a geographical variation. Latin America reporting 47 and Australia, for example, 51 years as a median age of menopause. Late menopause is over 55 years. Early menopause is between 40 and 45 years with a prevalence of 10%. In HIV, more frequently reported, and premature ovarian insufficiency is taking place before 40 years. And there's a prevalence of 1% in HIV, also more frequently reported. So if you find in your patient an amenorrhea before 45 years, then you have to measure the follicle stimulating hormone, and two values over 25 units per liter measured 6 weeks apart support you the diagnosis of early menopause. Why is this so important? Because women with early menopause, they have a great benefit from hormone treatment. Often I'm asked if hormone measurement might be helpful, but it is still a clinical diagnosis because hormones fluctuate a lot in perimenopause. If you see in the first line that in premenopause, the hormone fluctuation is quite regular, with having the estrogen peak before ovulation and having gestagen, progesterone only in the second half of the cycle. In perimenopause, in the second line of this graph, this looks more chaotic because the hormones fluctuate from day to day, and every month is also different. So a measurement in the blood will not help you to diagnose perimenopause. And in postmenopause, estrogen and progesterone are both low. The symptom burden, because we're talking about mental health today, is quite high. There's often irregular cycles, hot flushes, night sweats, and there's also mental health issues. The hot flushes might take place many years, with a median duration of 7 years. The sleep disturbances have also an influence on the quality of life and the mental status. There's vaginal dryness, dyspareunia, and reduced libido. And there's often poor concentration, like also called brain fog. The mood symptoms, I will talk later close about that, and joint pains is a typical symptom. In the general population, we say that 1/3 has no symptoms during menopause, 1/3 has mild symptoms, and 1/3 has severe menopausal symptoms. In HIV, we know that about 70% of women have vasomotor symptoms, and especially mental symptoms like low mood and anxiety. This is the menopause rating scale. It's an assessment scale you can print out and give it to your patient, also in the HIV clinic. And she can cross if she's affected by those symptoms mildly, moderately, or severely. And actually, then you can see if those women suffer from a reduced quality of life and need treatment during this phase. Mental health is very important because it's an important time in menopausal transition to take care about it. Menopausal transition can provoke mental disorders like depression and anxiety for the first time, but it can also make those, if they are already there, worse. During perimenopause, there's also cognitive changes, but they generally resolve in postmenopause, and they are not associated with a higher risk for dementia. Women with HIV have a higher burden of neurocognitive changes, so this is affecting learning and memory and concentration, but they also suffer from more frequent mood changes. The PRIME study showed that psychological distress was higher in women with somatic and urogenital symptoms. So if women suffer from symptoms and they have a high load of those symptoms, they have also more psychological distress. So this makes it more important that we ask for mood changes, and then we also ask for the menstrual cycle pattern if women are around 40 years old. You can see that there's a different estrogen receptor density in many areas of the brain before menopause and after menopause. So this is also influencing the effect of estrogen in the brain. And there's more research going on in seeing if estrogen can support mental health. We did in the Swiss HIV cohort a study about menopause transition, and we wanted to find out if menopause transition has an influence on viral suppression and adherence in women living with HIV. What we found is a really high rate of depression and psychiatric care with a prevalence of 27%, but we did not find an effect on adherence and viral load measurements. So what are the risk factors for mood symptoms during this menopause transition? As I said, it's the fluctuation of hormones, but it's also the estrogen decline. So there's a really rapid change in estrogen, and estrogen is closely related to serotonin and dopamine. And this is important if we treat those symptoms. Vasomotor symptoms and sleep disturbance, of course, hot flushes and night sweats can lead to poor sleep, and this is also a contributor to mood instability. Then there's the HIV-related factors, you all know that, the chronic inflammation and the long-term ART exposure. There's also the stigma, isolation, and relationship issues during that time of life. Often women have caregiving burden and they have some insecurity in their life issues. And there's also a special need for looking at people with history of mental health disorders. For example, if women were suffering from prior depression and anxiety, this might come back or be more severe during this phase of life. Also, watch out for substance abuse and comorbidities. So the treatment and management, first of all, we saw that genitourinary syndrome of menopause is very frequent in 2/3 of all women, and women might also be affected in terms of mental health by suffering from that. And it's a very easy treatment with no side effect. With vaginal low-dose estrogen therapy, you can apply cream or ring. And this is a very easy treatment, and it should be offered to all women because there's no side effects. Then we can offer menopausal hormone treatment. This is the most effective therapy, especially for vasomotor symptoms, but data is still very limited in women living with HIV. But what we know is that menopausal hormone treatment does also increase the effectiveness of antidepressive treatment like SSRIs. There's also non-hormonal treatments like plant-based treatments or psychotropic drugs like paroxetine And there's new treatment like neurokinin 3 and neurokinin 1 and 3 receptor antagonists. Those are especially effective to treat vasomotor symptoms, and they are non-hormonal. And of course, you should always adapt the lifestyle, and you should offer cognitive behavioral therapy and peer support. So the window of opportunity when we start hormones is in the first 10 years after menopause. And especially, we should not use oral treatment after the age of 60 years. So the benefits are symptom reduction, quality of life improvement, and in early menopause, we have also the effect of cardiovascular benefit, bone benefit, and the reduction of all-cause mortality. So I think you have always to find out if mood symptoms, if they are influenced by hot flushes and lack of sleep, you can always offer hormone treatment. How do we do it? We prefer a transdermal estrogen because it has no thromboembolic risk. And we add micronized progesterone 14 days or daily if women have a uterus. The vaginal estrogen I talked about can be offered also at the same time. So only 10% of people living with HIV are using hormone treatment at this moment because there's always concerns about drug-drug interaction, and maybe we have also women not diagnosed that symptoms might be due to menopausal transition. There's an increased risk of breast cancer, and this is one of the side effects of combined hormone replacement therapy. But as you can see in this Lancet paper, that there's an additional 4 cases in women with combined hormone replacement therapy per 1,000 women. But on the other hand, there's other risk factors that have the same risk, like, for example, taking the contraceptive pill, drinking alcohol, and having smokers, like cigarette smokers. And there's more risk in people who are obese and do not exercise at all. More than 24 cases of breast cancer. So I think we have to explain our women when they are very symptomatic that hormone treatment might be a benefit, still if with a little increase for breast cancer, and it can be sometimes used only for a few years, and compared to other risk factors, there's not so much risk. If you don't want to use hormones because there's a breast cancer risk in the family, for example, we can use the neurokinin receptor antagonists. And as you can see here, they work in the hypothalamus, and they are actually effective on the thermoregulatory center, and they have no effect on breast cancer risk. So they might be a good option to treat vasomotor symptoms. If there's a fear of drug-drug interaction, we can look at the Liverpool database, and you can see that in contraceptives, it's more important that we have a special level of progestin, but in the hormone treatment, we have no real level that we need because we treat symptoms. So actually, there's no dose adaptations requested, and there's no concerns in terms of drug-drug interaction. We did a fact sheet and an educational video also talking about mental health issues during that phase of life. You can see it's on the EACTS website, and you can download it for you and your patients. So first of all, I think there's major data gaps in women with HIV regarding menopause and regarding mental health. There's a cultural stigma and there's a lack of menopause awareness. So sometimes I think it's still underreported, and it does not give us an opportunity to treat it in time. We need for some specific tools for our HIV clinics because women mainly attend ID clinics and not always the gynecologist. And we need better guidelines for managing menopause in women living with HIV and collaboration with our psychiatric colleagues. So menopause is a critical but maybe a bit neglected aspect of HIV care, but the symptom burden, as I've shown you, can be high. And women with HIV, they have that double burden with the menopause symptoms, but also HIV-related symptoms. And I think mental health is such an important topic during that phase of life because the symptoms overlap, and we need really special awareness during that phase of life. So it would be a priority for me to establish integrated HIV and menopause services in collaboration with our psychiatric specialists. Thank you very much for your attention, and I'm looking forward to your questions.
Thank you very much, Caroline. Great presentation as always. This is a topic that you know very, very well. And you showed us beautifully that menopause is a process, a transition that can last for over a decade and affects every aspect of women's lives for years, for more than half their lives. As a clinician, what I would like to add is that sometimes in the early stages, you have to try and figure out the gray zone, figure out whether the symptoms are related to menopause or you have another issue. And this becomes especially difficult when you have younger women who don't have menstruation changes yet, but they come in with mood changes, with sexual health issues, sometimes with palpitations, and they start looking for, do an extensive workup to see if there is another issue there. So I think it's very important for us, for women over 40, to always, always ask if their period is, as always, if there had been any changes to their menstruation and to their sexual health. And please, we're ready to hear your questions, if there are some.
Так, дуже дякую,
Yes,
Каролайн.
thank you so much, Caroline, once again for very
вимушений сьогодні слідкувати за
interesting
часом, тому пропоную одне
lecture.
запитання із
I'm a
нашого
timekeeper
чату
today, so I
від наших
suggest
глядачів, і
we
після
take
цього будемо
one question
переходити до
from
нашого
our chat,
клінічного
from our
випадку.
participants, and then we will switch
Так,
over
наше
to our
запитання
clinical case.
з
So
чату.
the question from our chat
Caroline,
is as
який
follows.
антидепресант
Caroline, which
найчастіше
antidepressant
призначають жінкам
is
під
most
час
often
менопаузи?
prescribed to women in menopause, during menopause? Thank you.
Caroline, мікрофон.
A microphone. You are muted.
So which one is mostly used is in Switzerland is escitalopram as well, like Gita said. And actually, we also use plant-based therapy for the beginning. I think that's a really good, I mean, only the talking and being aware and giving and being conscious and telling the patient that this is a transient phase, because patients are afraid of depression and dementia. And you have to say that in the transition phase, this is only what it's, as Jota said, it's long, but it's not forever. It's a phase. So we can cope with behavioral therapy, with more with phytotherapy, but also if it's a depressive symptom, a severe one, we need, of course, antidepressants. But as you can feel, most of it is already talking, giving the empathy and saying that this will be a phase when and not for the next 10, 20 years. So this helps women. And we have to really be clear that they can talk to us when it gets more severe. And then we need a psychiatrist really to support us. This is how I do it, also in terms of what Jota said. So it can be like, it can improve, but it can be worse, and then we need a specialist.
Супер, дуже дякую за відповідь. То що,
Thank you
колеги,
so
я
much
тоді
for this
пропоную
answer.
перейти до нашого
Wonderful.
клінічного
Dear
випадку, і
colleagues,
після
I
нього ще
suggest we
трошки
switch over to
поговорити,
our
як
clinical
буде
case, and
складувати
then we will have more discussion
наш
after
клінічний
that.
випадок.
And our
Діагностика та
clinical
лікування
case is
депресивного
diagnosis and
розладу у
treatment of
жінки
depressive
з ВІЛ та
disorder
синдромом
in a
залежності
woman with
внаслідок
HIV
вживання опіоїдів,
and
яка також
opioid
знаходиться на
use
підтримувальній
disorder, and
терапії
who is
агоністами
on
опіоїдів Намтао,
opioid agonist
саме на метадоні,
maintenance therapy,
який нам
methadone,
представить Олег
namely,
Собко.
and this is
Пане
going to be
Олеже,
presented
прошу вас.
by Mr. Oleg Sobko. You're most welcome. Dear colleagues, hello to everyone. My name is Oleg Sobko, and I would like to present about the diagnosis and treatment of depressive disorder in a woman with opioid use disorder who is living with HIV and is on opioid agonist maintenance therapy. I do not have any conflict of interest. But before actually I present my case, I would like to explain the situation with mental disorders and substance abuse disorders in Ukraine. As of now, according to biobehavioral studies, there are 317,000 people in Ukraine who inject drugs, and a bit less for opioid users, 200,661, and this is according to the Center for Public Health. Patients who are getting opioid agonist maintenance therapy are 39,279, which is 19.5% of the estimated population of IDUs, and nearly 1 out of 3 people who inject drugs meet clinical criteria for depression, and approximately 1 in 4 people who inject drugs has attempted suicide at some point of their life. Also in Ukraine, there is a stereotype that people with depressive disorders should be referred to as psychiatric care for specialized treatment. That is why psychiatric care is very much stigmatized, and patients are reluctant to seek help there. And that was the rationale behind a research project that was supposed to demonstrate the feasibility of diagnosis and prescribing therapy within the context of non-specialized psychiatric service in Ukraine and how to treat depression. That is why, actually, the so-called MEDIUM project was established. And this study was conducted by the Ukrainian Institute of Public Health Policy with support from the U.S. National Institute on Drug Abuse, NIDA, and that was done over a period of 5 years. Results in this project were compared at the service level, SBIRT, patient level, and psychiatric quality of care indicators were actually looked at, as well as SSRI's participation in OAMT among 1,350 patients, of whom 82% were men and 17.6 were women from 4 regions or clusters and 12 clinical settings using a randomized controlled design over 24 months. And clusters were east, west, north, and south. And also, the people who participated in the project were divided into 3 observation groups. The first one, standard treatment. The second is ECHO SBIRT without additional P42 incentives. P42 is payment for performance. And 3, it's ECHO SBIRT plus P40. So there was a screening, brief intervention, and antidepressants were prescribed. In the second, ECHO telemedicine model was used to increase the level of qualification of healthcare workers involved in the project. And the third component to this project was financial incentives for the good results, good outcomes of the project. So using implementation science, the study examined the contribution of the patient, clinician, and institutional factors that would either facilitate or hinder primary and secondary outcomes. And also there was an analysis of the cost effectiveness of integrating services into clinics was done with or without financial incentives compared to a control group at sites where the maintenance therapy was performed. And also the Substance Abuse Treatment Department of the Prikapatia Regional Clinical Mental Health Center also participated in the study, and our facility was part of the cluster who was offering ECO, SBRT, and P4T. So we had 259 patients on OAMT. Out of them, 98.5% were screened for depression, 67.2% were diagnosed with a depressive disorder, and 54.8% received treatment with antidepressants. That was sertraline or venlafaxine. And I would like to mention that these medications were given free of charge to patients who participated in the project. With regards to screening and diagnosis, we used the questionnaire PHQ-2 that was done either by a nurse or a doctor, and there were two questions there. The first, how often have you felt down, sad, or hopeless over the past month? And the second one, how often have you noticed a lack of interest or pleasure in things that usually interested you or brought you pleasure over the past month? And the results were supposed to be entered either onto the screening form or directly in the patient's medical record. So if the patient answered yes to at least one question, then we continued the examination and we continued with a questionnaire with other questions, but that in that case, that was a MADRS questionnaire. And that questionnaire was good because it allowed for a syndromic diagnosis of a depressive episode and its severity, as well as we could monitor the efficacy of treatment using that questionnaire. According to that scale or questionnaire, MADRS, we were calculating the points. And this is Montgomery-Åsberg Depression Rating Scale, the MADRS, the one that we use. So 10 questions or to look at 10 functions, and that was done by a doctor. So the questionnaire was implemented by a doctor to assess the condition of a patient, to see whether there is a depression there or not, and what is the stage of the depression. So 7 to 19 mild, 20 to 34 moderate, and over 35 and above, that meant the severe depression. And now I would like actually to switch over to explain the clinical case. In our clinic, the patient is Natalia. She is 47 years old. She was on opioid substitution therapy since 2009. She began treatment for depression in April 2019. Her diagnosis: code is B20 HIV infection, clinical stage 4, esophageal candidiasis, chronic hepatitis B and C, and adjacent diagnosis, mental and behavioral disorders due to opioid use, addiction syndrome, and also moderate depressive episode without psychotic symptoms. And it's F32.1. Her complaints were the following: persistent low mood, lethargy, apathy, lack of desire, and loss of interest in life, marked anxiety, feeling of guilt. From time to time, she felt and she had suicidal thoughts, but she didn't have a specific plan. Also, there were sleep disorders, in particular early awakening, decreased appetite, weight loss. And over the past month, there was increased craving for illicit opioids. She had a desire to buy methadone on the street. Medical history. Opioid addiction for over 30 years. She has been on opioid substitution therapy since February 16, 2009, daily methadone dose 100 milligrams. Her first positive HIV test she got on August 23, 2002. She was monitored and treated for her HIV infection at the Center for Infectious Diseases in Ivano-Frankivsk. Antiretroviral therapy was initiated and she started to take it since 2009, but she was not adherent due to different reasons, like she stopped treatment from time to time, she didn't accept her diagnosis, she switched over from one regimen to another on her own, and also she had depressive symptoms, and that was over the past 6 months. And the triggers of that worsening of her psychiatric condition was her job loss and deterioration of her physical health. In January 2019, Natalia, having depressive symptoms, stopped ART on her own. And before her treatment was initiated, her mental status was like untidy appearance, facial expression was tense, she was oriented in time, space, and self, limited range of facial expressions, speech is slow, quiet, her mood was depressed, pessimistic thoughts of her future. According to PHQ-2, her score was positive, and when we assessed her using the MADRS questionnaire, she had 28 points, which corresponds to moderate depression. With regards to lab findings, the patient had CD4 only 62 cells, viral load 73,700 copies. With regards to renal tests, it was normal. Liver function tests were slightly elevated. And her treatment was as follows. Speaking about antidepressants, we chose sertraline. Why? Because it has minimal cardiotoxic risks and it's more safe for liver. Also, it has minimal drug interaction with antiretroviral therapy. We started with a small dose. Initial dose was 25 milligrams per day in the morning for 7 days. And that was done in order to minimize her initial anxiety and gastrointestinal discomfort, because sometimes such gastrointestinal symptoms happen in such patients. And that's common in HIV. And starting on day 5, that was increased to 50 milligrams. And after 3 weeks on sertraline, due to insufficient clinical effect, her dose was titrated up to 100 milligrams. And the duration of her therapy on that dose 100 was 12 months. That was from April 19, 2019 to April 13, 2020. On treatment, we saw some side effects like nausea and increased sweating. That was during the first week, but that resolved without any additional intervention. And according to the side effect assessment scale, FIPSR, that we used in this project, we saw minimal disturbances. They were present 10% of the time. And after her depressive symptoms subsided, ART was restarted, and that was done after counseling with an infectious specialist, disease specialist, dolutegravir, lamivudine, TDF, 1 tablet once daily. And the patient continues on this regimen up to this day. She is on this regimen. Also, I would like to mention, with regards the efficacy of her ART, on July 16, 2019, there was a blood test performed and her CD4 count is 264 cells and viral load 78 copies. And also the most recent data on February 9, 2026, her viral load was 20 copies and CD4 277 cells. That indicates actually the efficacy of ART, and it was a good choice to switch to a different ART regimen. With regards to her mental status assessment, we use the MADRS scale, and according to MADRS scale that we used, and we used it basically every 2 weeks. So before the beginning of treatment at baseline, it was 28 points, moderate depression. And the key symptoms at that time for Natalia, it was marked visible sadness, internal tension, pessimistic thoughts with regards to her future. Sometimes she had suicidal thoughts, she had reduced ability to experience pleasure, and also she had pronounced sleep disturbances. She woke up very early, and it took her very long time to get back to sleep. 2 weeks later, after antidepressive drugs started, we again did the assessment, and the score was 24 points. That meant that the dosage of sertraline was not enough. Of course, it was a not marked improvement, but the overall condition improved. Anxiety decreased slightly, appetite improved. However, melancholy, anhedonia, pessimistic outlook and thoughts remained. And we increased sertraline dose to 100 milligrams per day. And then in 2 weeks more, and that was week 4 basically, we also used the MADRS scale. The score was 20. It's moderate depression. And the patient became more active. Her mood stabilized. Her interest in her surroundings returned. Appetite normalized. The most important things that she did not have the suicidal thoughts any longer. And then week 6, 12 points according to MADRS scale. It's mild depression going on to remission. And the patient reported renewed interest in daily activities. She began making plans for future, tried to look for a job. Also, her sleep stabilized, and that was 6 to 7 hours per day. And there was almost no craving for illicit opioids. And her emotional state stabilized. That's why she almost stopped thinking about illicit opioids. So the conclusion about this case and what it demonstrates, that depression
treatment of depression in people with HIV and substance use disorders cannot be approached in isolation. Therefore, the integrated treatment approach is required, so substitution maintenance therapy, ART, and antidepressive drugs. The use of sertraline at the dose of 100 milligrams per day, monitored by MADRS scale, not only reduced depressive symptoms, but also directly brought the patient back to ART, thus eliminating the risk of HIV progression and relapse into using street drugs. With regards to the Medium project, it is still ongoing. But there are some preliminary conclusions. Number one, doctors generally have positive view on screening and prescribing antidepressants in patients on maintenance therapy. They have generally a positive attitude AD treatment. And also they like echo programs, but they are not very enthusiastic about the brief intervention, possibly due to the fact that brief interventions, they require more time and effort, and healthcare workers are not too much ready to use their time to do that. And as I have mentioned, the patients generally have a positive attitude towards antidepressive treatment, but they are not ready to buy such medications at their own expense from their own pocket. And the quality of service delivery depends more on individual staff motivation and institutional factors rather than on the proposed interventions. Also, it is expected that this approach will generate cost savings and increase coverage of patients with depressive disorders. And as long as doctors who work with maintenance therapy, they're more focused on depression treatment. Not depression, but addiction. But with regards to depressive disorders or other disorders of mental health, they pay not much attention to those. So it would be nice to have an integrated care and be provided at hospitals where maintenance therapy is given and where HIV treatment is provided and where the depression is treated. And also there is evidence that the quality of life for patients with maintenance therapy improves due to timely identification and treatment of depressive disorders. And from the point of view of public health, we can see patients bringing them closer to service providers, reducing the burden on specialized institutions, destigmatizing psychiatric interventions, and increasing patient retention in substitution maintenance therapy and adherence to ART. That's all from me. Thank you for your attention.
So may I say, if Sergey permits, thank you very much, Oleg. Thank you, dear colleague, for your quite a complicated, very interesting case. And of course, because we do not have time, although we would love to discuss the sertraline issue or some other drugs, but what's important to say? The most important, first of all, I would like to thank you for this case. That's for sure. Thank you for your experience. And what I would like to say is that, of course, the priority is establishing integrated services, especially for women with HIV, also opioid use disorder, who are on opioid agonist maintenance therapy. And in general, I also would like to add that as a practicing infectious disease specialist, dolutegravir can also lead to depression sometimes, but rarely, not very often. And it's very good that our patient that you discussed, that you presented, has undetectable viral load, and good that she is getting ART, one pill, dolutegravir-based one pill regimen, no side effect, and so that's nice. That's nice. I didn't see a lot of cases, actually just a few cases of depression on dolutegravir, which is important to us because the choice is not big in Ukraine. Probably 90% of our patients are getting dolutegravir in Ukraine. But it's much better compared to something else with this regard, right? So that is why, once again, I would like to thank you very much again, and probably we will complete right away because we do not have any time left. So in general, I would like to thank everyone. And probably we will have questions in the chat, so I guess the questions will be there, but thank you, Caroline. In our clinic, we are going to use that menopause assessment scale. That's relevant for Ukraine. We have a lot of women here. Maybe 115,000 people living with HIV are on ART, and more than 52,000 out of those are women. So the specifics of our epidemic in Ukraine is that we have a lot of infected women. Thank you once again. Of course, we do not have enough time, but lots of questions still to discuss, which is okay too, because the most important thing is our atmosphere. Of course, we will never be able to answer all the questions, but we were managed to do a lot. Thank you so much. I'm done. I am done. That was quick.
Я ще хотів додати єдине, що саме клініки
I just wanted to add
до
that
оформлення і залучення
OAMT is a good bridge to maintain patients on ART or to involve patients on ART,
людей, які живуть з ВІЛ, отримують АРТ. Тому це теж
because about 97% of people living with HIV are supposed to, like, they are on ART. That means that it's a contribution of our centers bringing them to ART as well. Thank you. Thank you. Yes, thank you. Thank you, everyone. This is not the last time. Of course, it's not. It's not. So considering lack of time, I suggest, with regards to your comments, maybe your final comments now, and we will complete. Who is ready to start? The final words.
Okay, so thanks a lot. I think it was a great experience to share these really problems for the real life in women, because the menopause is another part of the woman's life that we face many problems like depression, anxiety, and metabolic alterations that we don't have time to talk about, but we face these kind of problems. And the other side is also the drug addiction. That is very a hard problem in this population. So thanks a lot. It was a great experience to hear all of the speakers today.
So I would like to thank everyone. It was a great session. And I would like, before leaving, mention the elephant in the room, because I'm thinking for the last 2 hours where we're discussing mental health, that it's even more difficult to assess mental health issues and address mental health issues where a society is under, a difficult situation during a war, during a massive trauma and pressure to all the society. So it's even more difficult to tell apart the people that will benefit more from treatment and to tell apart the people who have actually a clinical issue bordering depression that you need to address. So I just wanted to say that we have great respect for you and the work you're doing in Ukraine in such difficult situation. And I was glad to be part of this session. Thank you very much.
Thank you, everybody, and thank you, Chota, for those words. You are right, and it's also for the healthcare providers important that we stay strong and keep ourselves up in terms of mental health and strength. And I think we learned a lot about the interaction between aging and stress and mental health today, seeing it from a psychiatric view, but also seeing it with the case now. I think this is maybe needs another follow-up webinar one day with more cases. I think we could really benefit from this. And thank you so much for everybody participating and for WAVE supporting this, and especially our colleagues in Ukraine and the NGO helping us with that. Thank you.
Дуже дякую, дуже дякую. Так, колеги,
Thank
якщо...
you. Thank you really very
Дякуємо,
much.
колеги.
Thank you,
Сергій,
colleagues.
вибач, я
Yes.
хочу
Sorry, sorry,
вибач,
Sergey. I
дякую.
just wanted
Закає
to
завжди
really say
мало
thank
часу,
you.
мало
Yeah,
часу,
and
багато
just to say,
питань. Там питання
not enough
всякі
time.
про
Lots of
вагітність, про
questions. There are
депресію
lots
після
of questions
вагітності.
about
Багато
pregnancy,
питань.
depression after pregnancy.
Але
So
ж
those are
важливо
questions
є
from the chat.
атмосфера. Атмосфера
But the
підтримки,
atmosphere is important.
можливість. От я
Atmosphere
думаю,
of
завтра у нас
support.
метаболічні
And
розлади, а
tomorrow
також
we are
жінка,
going to talk
яка
about
і
metabolic
депресію має,
disorders.
і
And there
Олег
is a
нас
woman
буде,
who has
нам буде
depression
дуже,
there
дуже
to be
нам
discussed.
будуть
And
потрібні
Oleg
психіатри.
actually
І
is the person that we would need tomorrow
я згодна,
in
що
for our
треба
women
ще,
case
треба
with
ще
menopause. So I agree, we
повторювати.
need
А
more.
те, що
We
ми,
need
ну,
more
2 часа
discussions
урок,
of those
да, але
topics.
життя таке багато. Дуже вам
Yeah,
дякую,
but
що ви
it's life.
зважаєте на
It's
вашу
life. And thank
зайнятість і
you very
нашим
much that
лікарям,
regardless
що незважаючи
of
на це,
for you
ми
being
змогли
busy,
за
lots
2
of work,
години
still we were
про
able to
це
allocate
говорити.
2
І
hours of
я
our
думаю,
time to
що
talk about that.
найважливішим є натхнення.
And the
Натхнення
most important
працювати
is again
краще.
inspiration,
Дуже дякую
inspiration
і
to still
українським,
go
і
on
нашим
and work
європейським
better. Thank you.
колегам. Ви
Dear all
надихнули нас
colleagues,
на
European,
покращення
Ukrainian
роботи
colleagues, you have
з
inspired
нашими
us to
пацієнтами.
go on,
І
to continue
хочемо
to
знов
work and to work
спілкуватись
better.
до
Of course, we
зустрічі ще
will
раз. Дуже дякую.
continue to communicate. See
Сергій,
you next
вибачте.
time.
Так,
Thank you.
колеги,
And
щиро дякую вам.
thank you.
Це було
Sorry, Sergey.
дуже
Yes,
класно. Я
colleagues.
хочу
Thank
знову
you,
ж
everyone. That
нагадати,
was
що завтра у нас буде
wonderful.
другий день.
Just
Ми
to
розглянемо
remind you,
метаболічне
tomorrow we have our
захворювання
second
різних
day.
типів
It's
ВІЛ.
about metabolic
Ну, а на
disease,
сьогодні все.
living with HIV.
Всім
And
щиро
that's all
дякую.
for today.
Побачимося
Thank
завтра.
you once again to
До побачення.
everyone. See you tomorrow. Goodbye.
До побачення.